Hello, and welcome to Religion and Life. I'm your host, Ozzie Ostwallt. In a world defined by a global pandemic, some people have asked the question, what can religion offer, if anything, to the questions surrounding public health? My guest today deals with that question every day. Dr. John Belvin is here to help us gain insight and answer questions about the interrelationship between religion and public health. Welcome, John. I appreciate you joining us today.
Thanks, Ozzie. I appreciate the invitation. I'm glad to be with you.
Yeah. So you wear many hats where you work. You are the Director of Interfaith Health Programs at the Rollins School of Public Health, and you are on the faculty there. And you also work in connection with the Candler School of Theology, all of that at Emory University. So maybe you can, how do you juggle all those different roles? And maybe you can describe what your primary role is there in the Rollins School of Public Health.
Sure. So Emory is distinctive from some of its peers as research universities in the United States in having a long-standing history of examining how religion impacts and influences public health. And we do that both from interdisciplinary perspectives as well as through pure research and scholarship and applied research and practice. So we're a nice balance between those worlds. Our program started, the Interfaith Health Program, which I direct, started over 25 years ago, first at the Carter Center, at the center affiliated with Emory in Atlanta, founded by former President Carter. The director at the time was a man named Bill Fagey, who had been the director of the CDC under President Carter and was the director of the Carter Center. Bill had been involved in the U.S. Public Health Service effort to eradicate smallpox in the world, and had been part of that intergovernmental effort. One of the only instance in which we fully eradicated is a disease from the face of the earth. And he did that through a lot of public health knowledge, but also a lot of knowledge about what matters in local communities to carry out epidemiology, surveillance, and response. And a lot of that was to recognize the power of faith communities, local congregations, temples, masjids in local communities, and the trust that people who are part of those faith communities place in that faith community and in those religious leaders. Bill himself is the son of a Lutheran pastor, and he had been a medical missionary to Liberia. So when the Carter Center was looking at ways to address health inequities and other kind of socioeconomic and structural inequities, starting in the U.S., Bill convened a meeting of religious leaders, and that led to the founding of the Interfaith Health Program. We've been around for a little over 25 years, and we're located in the School of Public Health. We exist to look at the ways that religion shapes people's concepts of health, their health beliefs, their health behaviors, and their health practices, and how religious institutions and religious organizations can be important partners in a public health response. I do that work as someone coming out of theological studies, and as you mentioned, I have a joint appointment both with the School of Theology and the Graduate Division of Religion at Emory, which is also one of the distinctives about Emory. We have a seminary as one of our professional schools here at the university. We also have a large and well-regarded graduate and undergraduate program in religious studies. And so we can look at religion from a variety of perspectives. We're not bound by any kind of confessional tradition alone, and we can take religion seriously, but look at it broadly. So Emory's got a good history of doing that, and I feel really fortunate to have the opportunity to work on those programs with colleagues here.
That's really a great combination of resources there to draw both from a divinity school with the confessional perspective and a department of religion with a non-confessional perspective, and then the public health perspective and the science as well. As I was listening to you talk, it occurred to me that probably, and maybe I'm reflecting on our contemporary situation a little bit, but I would guess that oftentimes when public health officials who are predominantly scientists, right, get involved with these issues, that maybe they sometimes forget that certain things like religion are important when people are facing public health crises or matters of life and death. Is part of your role to remind the scientists that religion does matter in situations like this?
Yeah, I think so. I'm laughing because part of my role also is to remind colleagues in public health, many of whom come out of an academic tradition that's quite secularist in its way of approaching a problem and a question. Not only that religion matters to many people in many parts of the world. A lot of my work is in global health, and I just argue that to understand global health and to work in the field of global health, you have to take religion seriously. You have to not just dismiss it. I think Emory has gotten to the point, and colleagues in the School of Public Health have gotten to the point that we no longer dismiss religion. But I do think we still have a tendency, some of my colleagues, to want to use religion for as a means to achieve what they want to achieve. And so happy to partner with religious partners, as long as those religious partners are going to fashion a program and be part of a collaboration that follows and reflects the public health practitioners and public health researchers' priorities. One of the things I often remind my public health colleagues is that engaging in culture doesn't just mean finding ways to respect another culture. It's interrogating your own starting point. And public health reflects a certain kind of culture, and we need to do a better job, in my opinion, in the field of acknowledging our own priorities, our own values, our own commitments, rather than just assuming that because we say we're grounded in science, we're objective in regard to our practice and our engagement. So,
yeah, well, maybe, and then some of your work has been with HIV and AIDS prevention and relief, and maybe you can give us some concrete examples of how, with your work with HIV and AIDS prevention, and I guess predominantly sub-Saharan Africa, how do all those forces come together in a situation like that? Because you've got religion, you've got different culture, you've got the science perspective. It seems like that would be navigating a minefield.
Yeah, there are a lot of factors involved in the field of HIV, and I've been involved in that work for all of my professional career. My first job out of seminary was working as a chaplain to adults and children in the early 1990s in Chicago, who were living, and at that time, many dying from HIV and AIDS. But you're exactly right. Religion's influence in the global HIV response is powerful and also multiple. And so one of the ways in which it's really important to build partnerships with religious leaders and with religious organizations in the global HIV response is because, particularly in the sub-Saharan African region, faith-based health systems, which are national networks in 28 countries around sub-Saharan Africa, they provide a parallel national structure for health service delivery that's really essential for meeting the gaps that the national health systems in those countries just cannot overcome. And without those faith-based health networks and health systems in place, the quality of life and the capacity to provide HIV clinical care really isn't possible. Across the region, probably about 20 to 25% of all HIV services are provided by faith-based providers. I can give you a concrete number out of Kenya, where we've actually studied to quantify that, and 28% of all HIV visits in which medicine to slow the progression of the virus down, 28% of those visits are carried out by a faith-based health provider. And so from a public health perspective, in terms of managing HIV disease, that partnership is really, really essential. It's the second largest sector for the clinical response to HIV behind the government. But it's not just the clinical issues that are on the table. As we know, HIV is also a cultural issue. There are lots of perspectives, both historically and in the present day, in debates about how someone was infected and the meaning given to that, the kind of moral framework around sexual behavior and sexual risk that often comes into play in regard to HIV when it is transmitted through sexual practice. And religion can be a really powerful driver, both as a driver of HIV-related stigma. If you want to make stigma have greater kind of power in a local community, convince the people who hold stigmatizing perspectives that their perspectives are ordained by God, and that gives them a lot more of a sense of their own kind of moral rightness in regard to that stigmatizing attitude. Conversely, that religion can be a really powerful factor for challenging that very kind of stigma. And so it's much more effective for a local pastor or a lay person or an imam to challenge HIV stigma, particularly religiously framed HIV stigma, than it would be for a public health researcher or practitioner to challenge it. Because someone who's inside of a religious tradition can speak back to the dynamics about that stigma in a way that's an internal discussion and debate and discernment within a religious context and within a religious tradition that a public health practitioner just can't do. So a lot of our work is also looking at how we build partnerships with interreligious partners, Christian, Muslim predominantly, to challenge and to highlight alternatives to stigmatizing perspectives for those who are living with or at risk for HIV.
Yeah, and I guess with HIV in particular, that moral framework that you mentioned, and the stigma that is often attached to HIV/AIDS complicates your work greatly. And yet you mentioned that religion could either be a helpful factor. That 28% number blows me away. That religious institutions played that big a role, but also a hindrance factor as well. Which really kind of leads to my next series of questions. Of course, we've been dealing with the COVID-19 pandemic for over a year now globally, and you have written that in this pandemic, religion can either be a helpful force or a hindrance, as you mentioned with HIV work. But regardless, it's a force, right? It's a powerful social force. So I'm wondering if you could maybe give us some examples of how in this pandemic, religion has been both helpful and a hindrance as we try to fight the spread of COVID-19.
Sure. I'll give you a couple examples of each. In the United States, over a year ago now, or about a year ago, as we were all it was dawning on us that we were looking at something we had never experienced before globally in terms of this pandemic. A local Presbyterian minister here in Atlanta and a Jewish rabbi here in Atlanta established a Facebook group of spiritual resources for religious and spiritual leaders to respond to COVID. That Facebook group grew within days to over 6,000 members. It's a moderated group. People began to share examples of strategies and best practices, way to move worship from in-person worship to online worship, asking difficult and important questions about the equity and inequity between congregations that had that platform for doing that and congregations that didn't. How did we provide for spiritual care for communities that may not have a technological infrastructure? So debating those kinds of issues, helping each other with resources for pastoral care, and checking on homebound members in the early days of the epidemic, advocating for social distancing and strategies to mitigate the risk of transmission through mask wearing, and to frame that in a theological framework to draw on religious teachings out of various traditions that reflect what we often call the golden rule of doing unto others as you would have them do to you. And that's an important way that religion was a resource. At the same time, and globally as well, a lot of work to address COVID in the global context. A religious leader speaking about COVID has much more authority for a member of a local congregation, quite often, more often than a public health practitioner or a medical doctor would have. They're quite often what we call in public health trusted messengers. And the way in which the words that they give, the framework they provide, can be really essential for building trust and building a kind of community and population level response that reflects sound and evidence-based public health practice. At the same time, religion could be a hindrance to and a barrier to public health responses that we know work. We've seen debates in the United States about mask wearing. We've seen debates in the United States about vaccine safety. We've seen debates in the United States about how and when we should reopen all kinds of institutions in our communities, including houses of worship. And those kinds of debates aren't only happening in religious contexts, but they are happening in religious contexts. And religious leaders put forth frameworks and have put forth frameworks that have been in tension with public health practice that we know that can lessen the spread. And finally, I think one of the things that it's important to acknowledge is that public health sometimes needs to be corrected around its assumptions about religion. I said a few minutes ago that public health often thinks of wanting to partner with religion and with religious institutions and religious leaders, as long as those institutions will do what public health wants them to do. But around questions of reopening houses of worship and gathering for worship in person, I've had discussions with public health colleagues on the faculty here at Emory who've been really frustrated to hear religious leaders say that. And I said, have you assessed whether what they're doing is actually minimizing risk? Are they taking steps to lower transmission and to mitigate the possibility of spread? And they said, no, they shouldn't be open anyway. And so I said, so are you teaching in person in your classrooms? Have you been out to eat? Have you been somewhere in a public setting where you might expose have you been to a grocery store? The fact that religious worship might not be important to you doesn't mean that it's not really important to someone else. And the question isn't whether we should be doing it or not. The question is, how do we do it to minimize risk? That's both a public question and a theological and spiritual question, it seems to me.
Yeah, those are really, I think, insightful comments. I know in the early days of the pandemic, when we were debating about what to do with worship in various congregations, those two positions kind of emerged. There were ministers who helped to ease people into alternative forms of worship and in essence say it's okay, right, to not be in church in person for a time being. And others who seem to kind of relish the risk of disease as being less important than displeasing God or being, in a house of worship. So I could see both of those dynamics going on. And in light of obviously COVID has changed worship practices globally. We see it in the U.S. We see it in my small community. Maybe some of those changes will be permanent. We don't know. But it seems to me that one of the things that has been missing in discussions is kind of a really powerful and relevant theological message that goes to the heart of the pandemic and some of the issues related to it. And I read a piece that you wrote that really resonated, which shaped a theological response to COVID-19 around the concepts of liberation and creation. And I'd like for you just to kind of share that with our audience. I think it's a creative and powerful way of thinking about a theological response to COVID-19.
Well, thanks, Ozzie. I appreciate that. Happy to summarize that piece. First, I think it's important for me to acknowledge that the ideas in that piece really, in terms of the concepts of liberation and creation, aren't my own. I borrowed them from a colleague who was a professor in theological studies at the University of KwaZulu-Natal in South Africa, in Pietermaritzburg, a theologian named Steve de Gruchy. Steve unfortunately died in a river accident. He died on the Moy River in South Africa, but he did a lot of work to establish the area of religion and public health and faith-based partnerships for public health initiatives globally. And one of the things, the kind of core theological question for Steve when he died was the question of water. So it's kind of ironic he died in a boating accident on a river, but he knew that the world was facing a coming water crisis and that safe water availability was going to be one of the pressing issues in the 21st century. He wrote a piece drawing out of the work in South Africa to employ liberation theological perspectives in the fight against apartheid, and ask a really provocative theological question around the question of water availability. And he asked if God has a preferential option for the poor, which is a primary claim of various liberation theological positions. If God has that preferential option for the poor and the marginalized, how do we wrestle with the reality and the fact that disease has the same preferential option? That poor health outcomes, greater illness, greater and higher rates of death happen among the poor and vulnerable. And what do we do about that theologically? And what Steve really began to push around that question, and I referenced his ideas in relation to COVID, is that in the context of vulnerability, it's really important to articulate and to testify to how God is working to bring people out of a place of vulnerability, to give the testimony and the narrative of liberation and Exodus, to use the Exodus narratives in Scripture to describe how God is at work to deliver those who find themselves in vulnerable places. But in regard to the issue of water, if we find ourselves in a place where we're fortunate enough to live in a household and to be part of institutions where we can go into a kitchen and turn on a tap and water that's safe to drink comes out and it's available to us, the question for us isn't one of liberation. The question for us is one of stewardship. And what does it mean to recognize that we have one creation, we're part of this earth, and that in regard to that creation, we have a responsibility to care for it and to care for one another in it. And the inequities that exist, Steve argued, are evidence of our failure to be good stewards of that creation. I think in regard to COVID, what that calls us to is to ask some pressing questions about how we message COVID prevention messages. A lot of the initial responses about COVID in regard to reducing risk if someone in your household is exposed, assume that you would have a household that looked like a middle-class household in the United States. You'd have access to a private bathroom, a separate bedroom. Most people in the world don't live in such a household. They either live in extended family networks in a large enough house that there's multiple bedrooms, or they may live in extended family networks or in a nuclear family, but they may live in one room alone. And so we need to do a better job of developing messages, but also addressing the inequities that exist in things like our housing or in our risk of COVID infection. Yeah. Part of that is to acknowledge the structural inequities that exist between lower and middle income countries in the world and richer countries such as the United States, and to acknowledge and to confess the inequities that exist in the United States across different socioeconomic and cultural groups. And so the piece that I wrote was asking us to think theologically about the power of liberation and the power of Exodus, but also the power of staying in place and caring for God's good creation in a way that reflects justice and equity.
Yeah, that's really a powerful point. And what it brought to my mind is, as we begin to think about emerging from this pandemic, they're going to be, like everything else, the way we behave and the way we go about our lives in upper income countries like the United States is not just going to affect life in the United States, but will affect sometimes detrimentally life in lower income countries. And I think that's been something that I think has been missing from the discussion and will become more and more important as we go forward.
I agree. That comes out most clearly right now and will come out in the coming months around vaccine availability. I'm glad that the United States has entered back into the World Health Organization and is helping to support a multinational global response to encourage vaccine equity, a global initiative called COVAX. But it's really important that we ask ourselves those kind of questions about inequity and what it means if we're on the side of benefit around that inequitable distribution, what it is then to do about that, not just to name it, see it, spot it, but what's our obligation to respond to it, and how do we do that?
Yeah, and I judging from the type of work you're doing, I'm hopeful that religious organizations will continue to kind of forge leadership roles in this area. And do you see that happening in the United States and elsewhere?
Yeah, I mean, I think definitely in the global COVID response that religious organizations have been important partners with multi-sectoral responses to COVID, important partners in the civil society responses in each country, but also in kind of global networks, regional and global responses. That's both in terms of their capacity to message and to provide services that I mentioned before. It's also an important capacity and an important responsibility in regard to their advocacy work. One of the important things that religious leaders and religious organizations can do in global advocacy efforts around public health, and we learned this in the HIV response, is to advocate to hold funders, national governments, local communities responsible, and to hold their feet to the fire to respond to need in an equitable way and in a comprehensive way, and not to give lip service to that, to call inequity out when it's occurring. And religious leaders and religious organizations have been really important and powerful messengers in that regard, both in the U.S. and globally.
Yeah. Well, John, this has been a fascinating discussion. I'm so impressed by the work you're doing, the work that the Rollins School of Public Health is doing. So important and relevant right now where we find ourselves at this point in history. So thank you not only for coming on this program, but also for the great work you were doing. I appreciate it.
Thank you, Ozzie. I appreciate you having me today.
Yeah. Well, that's it for Religion and Life for this week. I hope you'll join us on AppTV next time as we continue to explore the role that religion plays in society and culture. Until then, this is Ozzie Ostwallt.